The Community Memorial Health System Fall 2021 Speaker Series Online is brought to you by Mission Home Health. Mission Home Health and Hospice is committed to taking care of people by providing the highest quality, cost-effective care wherever the patient calls home. With over 14 locations, Mission delivers skilled home health, hospice, and palliative care services to more than 3,000 patients a day. As a preferred partner with several health systems, Mission works with providers to customize each partnership to provide exceptional coordinated care. Visit our website to learn more at www.homewithmission.com. We take care of people, and one call does it all.
Good evening. My name is Dr. Marc Beaghler, and I'm the head of robotic surgery at Community Memorial Hospital. Tonight we appreciate you joining us for this event. We're going to talk about robotic surgery in general, and then we're going to have two different speakers, Dr. Pahlavan and Dr. Burge, talk about both spine and orthopedic applications of robotic systems that they're using in their practices. So we'll begin by showing you a short introductory video, and then I'm going to do a quick PowerPoint presentation followed by some questions and answers.
We've integrated what we've learned from our customers and what our design teams have invented, and now we're proud to present the Vinci Xi. The Vinci Xi is our fourth generation of Da Vinci system, and it has in it over 20 years of learning how to enhance surgical performance by creating a natural extension of the surgeon's eyes and their hands.
This new product features fast 4-quadrant surgery, substantially improved vision, and is a scalable platform for all our advanced technologies. The overhead boom allows the arms to rotate as a group, and this frees up valuable space inside the surgical field, allowing unobstructed access to the patient. This is all enabled by smaller, lighter arms with extended range of motion and improved reach inside the body.
Making the system much easier to use was a primary focus of developing the Da Vinci Xi. Docking is facilitated by a laser targeting system. Point the endoscope at the surgical site, press the targeting button, and the system will configure itself into the optimal position for the procedure.
The new endoscope is much easier to use. No more draping, calibration, white balance. You just plug it in and go. With this new architecture, you can put the scope in any one of the arms, and it gives you a lot more flexibility and setup.
At Intuitive, we strive to create the safest, least invasive option for surgery. And we believe deeply that minimally invasive surgery should be the standard of care, and we work hard every day to make that a reality.
Okay, so at this time I'm going to go through a presentation on robotic surgery at CMH. I'm the medical director of the robotic program, and I've been at CMH involved in this program. We started it in 2005, and for general surgical applications, for urology, for gynecologic applications, and other applications, we've grown this program from a very small number of cases to a very large number of cases, and we'll go through that in a minute. There are a number of reasons why robotic surgery is useful in these surgical lines, and a lot of it has to do with better instrumentation, visualization, which is improved using the robotic system, and precision. So the Da Vinci surgical system is a robot that is used for laparoscopic surgical treatment. The surgeon sits at a console, and he controls the instruments remotely. All the instruments are put in by the surgeon before the beginning of the procedure. The field of vision is excellent with a large magnification of what we would typically see in an open surgical arena. The Da Vinci system uses instruments that really work as an extension of the operating surgeon's hands, and so the surgeon is controlling all aspects of the surgery. Vision is three-dimensional, and as I mentioned previously, it is magnified, so the view that the surgeon has is improved over both typical laparoscopic procedures and certainly open surgical procedures. The instruments are unique in that they're movable and have 5 different degrees of freedom, just like your hand does. The benefits of robotic surgery are that it can be used in multiple applications: urology, general surgery, gynecology, cardiac surgery, and we've found, and multiple studies have shown, that there is reduced trauma to the body, there is reduced blood loss, and that many patients' stays in the hospital can be shortened. Actually, a lot of the operations are done and the patients are discharged from the hospital the same day. There's less scarring, and there's obviously a potential for faster return to normal activities. The system here at CMH was started by us and some other surgeons, and it was really pioneered for urologic applications for both partial nephrectomies, and prostatectomies. This technology has grown. Other surgical fields have developed interest, and now it's widely applied in general surgery, gynecology, and in cardiac and chest surgery. Surgical procedures that are done at CMH: robotic prostatectomies, radical prostatectomies, and simple prostatectomies, complex urinary reconstructive procedures, nephrectomies, gynecologic procedures, and complex general surgical applications are common. As I mentioned, our program started in 2005 and has grown consistently year over year. At this point, we're on track to do over 659 cases in 2021 if you look at all different surgical fields. If you look at cases done by service line, general surgery, gynecological surgery, urology are the bulk of the cases that are done at CMH, with growth year over year in each service line. Currently, you can see the number of surgeons that we have that are robotically trained and that are doing cases at CMH. Previously, at the start of this program, this slide would have had 2 or 3 different surgeons on it, but now you can see that we are at a much greater number of surgeons and surgical fields. So now I'm going to allow some time for brief questions on robotic surgery in our program, and then Dr. Burge will talk about the Rosa knee replacement procedure. So one question that we have is, how is Da Vinci surgery better than traditional laparoscopic surgery? Well, in typical laparoscopic surgery, it's really, for the surgeon, it's like operating with chopsticks. And so with the Da Vinci system, the instruments are much more precisely controlled. I believe the visualization is better, and the ergonomics for the surgeon doing the case is much better, because they're sitting at a console in a much more comfortable position with better visualization and really with better instrumentation. How do you know? The next question is, how do I know if I'm a good candidate for a Da Vinci procedure? Well, you don't know, and that's going to be determined by your physician. Not every person is going to be a candidate for robotic surgery. If they've had a lot of previous operations, or they have other conditions, have had previous radiation, they may not be an ideal candidate for robotic surgery. So it really is variable, and it depends. It also depends on the experience of the surgeon. Do most insurances cover robotic surgery? That's an excellent question, and the answer is it depends. There are additional charges and costs that really the hospital absorbs, but if you're in a closed HMO system, for example, they may not authorize all procedures to be done robotically that we may traditionally or currently be doing robotically. But for the most part, most PPO insurances, Medicare, Medi-Cal, and non-closed systems, that is not really an issue. Do I have to stay overnight in the hospital if I have a Da Vinci surgery? Well, again, that depends on the type of surgery you have. It depends on your age. It'll also depend on whether you have other comorbidities or conditions that would lead you to need to be hospitalized. And it also depends on the nature of the surgery. What I can tell you is that our team, Dr. Poon, and Dr. Kadami, are doing many of these cases where we traditionally did keep patients overnight. Many of these patients are going home the same day. Will the surgeon be with me in the operating room during the procedure? Yes, the surgeon and his assistant are in the operating room at the time of your procedure. The surgeon sits at a console after he has placed all of the instruments in laparoscopically. So the surgeon is there, absolutely, in the same room. Does it cost more to have robotic surgery? It doesn't cost the patient anymore. So, to you, whether it's done robotically or you have an open surgical procedure, the cost is the same. Let's see. Last question. How does the surgeon control the Da Vinci surgical system? All right, so what happens in a typical, let's take a urologic case. The surgeon will do a traditional laparoscopic procedure. The instruments will be placed. The instruments will then be attached to the robot, and then the surgeon will sit at a monitor and he will operate those instruments remotely. And at the end of the procedure, the instruments will come out, and then he'll close all the incisions, and that will terminate the procedure. So with that, I think we'll move to the next speaker, who is Dr. Burge, and he's going to talk to us about the Rosa knee system.
Rosa Knee is a robotic surgical assistant for total knee replacement. Your surgeon is specially trained to use the robot. Rosa Knee does not operate on its own. Your surgeon is in the operating room the entire time and making decisions throughout your surgery. Your surgeon creates a plan for your surgery based on your unique anatomy. The robot helps to ensure the plan is executed as intended. Rosa Knee uses a camera and optical trackers to know where your leg is in space. If your leg moves, the robot can tell and adjusts accordingly. Rosa Knee provides your surgeon with data about your knee. This helps to personalize your surgery based on your unique anatomy. To learn more about total knee replacement with Rosa Knee, call toll-free at 1-800-447-5633 or visit ZimmerBiomet.com.
All right. Hey, I'm John Ross Burge. I'm a hip and knee reconstruction specialist with Ocean Orthopedics here in Ventura. We also have an additional office in Camarillo. And I'm going to quickly go over Rosa robotic knee replacement, which is a Zimmer robot used in the Community Memorial Health System in Ojai, and the bulk of the volume's done in Ventura. So this is a picture of my website just for additional information. Tonight's talk is to just try to go over just some basic information. You've seen the video. Hope you had your popcorn for that. And then at the end, we'll go through some quick questions and then hopefully answer what you guys really want to know about it. So why robotics and what is a robotic knee replacement? So robotic knee replacement uses conventional instruments as well as computer navigation, and then the newest aspect of it is the robotic arm. There are 6 primary cuts that are made in order to shape the bone for the total knee that is put in the prosthesis. So the robotic arm uses computer navigation to help us make perfect cuts, and that's how it's used primarily in this. It's a little bit different than the Vinci robot that Dr. Beaghler just discussed. So again, why use robotics? What's wrong with modern total knee replacement? Well, overall, there were some landmark studies done in Canada and the US that showed dissatisfaction after a total knee replacement of around 15%, some even as high as 20%, which is considerable. So why do total knees fail? Well, over time, the cement bone interface can fail, and that's called loosening. So the prosthesis can loosen. That's the most common reason currently. And then the second most common reason would be infection, which is about a 1% infection rate after a total knee or total hip arthroplasty. And then after that would be pain and stiffness. Now with this dissatisfaction rate, we have to kind of figure out, so why exactly are patients unhappy? And that breaks down into patient factors and surgeon factors. So on the patient side, there's expectations and knowledge. So in partnering with patients to try to figure out when they're a candidate for total knee arthroplasty, there is no special consideration for robotics, just meaning that when we talk about indications for robotic total knee replacement, anyone who's a candidate for a partial knee replacement or a total knee replacement can usually have a robotic total knee replacement. The caveat would be that there are some, maybe a very minute percentage of patients that may have some pre-existing hardware or severe post-traumatic deformity that it may not be realistic to incorporate the robot. However, I've used it for those situations because it significantly improves the accuracy in those cases and helps troubleshoot dodging some of the hardware. So with expectations, we partner with patients, and we really have to make sure that patient expectation is on, that they know exactly what's going to take place, the pain that they may experience post-operative, what are our primary goals, what is a total knee replacement, and how the rehabilitation process will take place. All of those are critical for improving satisfaction post-operatively, as well as the knowledge on the part of the patient. And then the surgeon factors would be soft tissue balancing, the bone cuts themselves, and then the sizes of the implant, so appropriate implant sizing and placement. And that's where the robot comes in. So we discuss alignment, so the alignment of the knee, and this is a subject of heated debate over the years. It kind of swings one way and another. And when we try to come to a consensus on this, what is this based on? Well, those 6 primary cuts that I was discussing earlier, there's been a lot of studies and data on this, and some of the traditional instruments that we used prior to the advent of robotics, they're actually based on averages. And these averages come from studies where they've done CT scans of several thousand patients in Brazil and the United States and some other countries, and they measure the average angle of the distal femur, or the rotation of the femur as it communicates from the hip down to the knee. And then they come up with averages, plus or minus 3 degrees one way or the other. And it actually turns out that about 15% of people or patients fall outside of these averages. So when we use traditional knee replacements, not meaning some kind of computer navigation or robotic system, that there is a certain percentage of patients that fall outside of that. And then also we have to talk about the accuracy of cuts when we use robotics as well, because that's a critical component. Now, when we review the literature, we're still in the infant stage or infancy of robotics used in orthopedics, specifically for knee and hip replacement. So this is going to continue to evolve over time. The biggest thing is we get so much data from these cases that we're still trying to fully understand how to utilize and give appropriate feedback with that data to help improve satisfaction rates with total knee arthroplasty. One of the big things is that we do have data that shows that there's improved recovery in the first 6 weeks regarding pain and physical therapy after robotic knee replacements, and we've actually seen that just anecdotally in our own experience here. So going and looking at the technology just a little bit, just a brief overview. The actual computer navigation component of the technology was developed in 1996 for the use in spine surgery, and that has since turned into a little bit more involvement in the balancing of total knees. And then it wasn't actually until 2019 that it became FDA approved in the United States for use in robotic total knee replacement. So these are just showing examples that this specific robotic system can be used with or without x-rays. So we try to obtain a specific x-ray for this machine so that we can send those images to engineers in Montreal. Then they kind of send us back a template or a plan to see if they agree with our plan, and they tell us roughly within one size what the implant sizes for the tibia and the femur should be. We can do this with and without x-rays because a lot of this information we obtain during the case anyways. It's just nice to have the plan ahead of time. However, it's not always convenient for patients to get these specific x-rays and get them sent to Montreal before the case. It only needs about a 10-day turnover, which is much faster than some robotic systems that rely on CT scans that must be done several weeks in advance and significantly increase the cost of healthcare. So this is looking at a study on cadavers, and they looked at the accuracy of cuts with conventional instrumentations, which are standard total knees, computer navigation, which was developed in the 90s or FDA approved in the 90s, and then the current Rosa robot total knee arthroplasty system. So when we look at these, you see conventional bone cuts according to the plan that was put in place. The accuracy is around 69 or 70% with conventional total knees. With computer navigation, it does jump significantly to 87%. And then with the Rosa robot, within plus or minus 3 degrees of the original plan overall, it's 100% accurate. And then this is a picture of my team in Ojai performing a robotic total knee arthroplasty, so we're all set up with our gear there. Although the bulk of cases with the robot, because we have 2 robots at Community Memorial in Ventura and 1 robot in Ojai. And then here are some pictures actually from surgeries that I've done in the last 18 months. These aren't of the bones themselves, but this is what the computer screen looks like, and these are all the different things that I can adjust, which is awesome. It shows the millimeters of the gaps on either side of the knee when I'm trying to balance this. I can adjust the varus or valgus cuts, the rotation of the femur, the slope of the tibia, the flexion extension of the femur. There's so many different variables involved, and it's a lot of information. So it can be very personalized to each patient. And then this is a shot from the side, just kind of showing the other aspect of this, looking at it in flexion from the lateral view as far as rotation of the components on the femur. And then this last slide is a picture of my beautiful family, my daughter, my dog, and my wife. And shameless plug for Ghostbusters. My daughter's the star of the new Ghostbusters movie that premieres tonight, so I had to throw that in there. And then I think we'll take some questions just regarding Rosa robotic total knees. Okay, so first question, can robotics be used in hip revision procedures? Yes, it can. It actually can. Currently, the Rosa robot is not used for that. There are some other robotic systems. However, I don't think that they're currently FDA approved for this, so they would have to be used off-label. Currently, in the hip total arthroplasty procedures, I don't feel like you gain a lot with the current systems. I think in time, as robotics evolves, that they will have better utilization or a higher purpose in these revision procedures, but currently I don't think it would add much to the procedure. I think that's something better done without a robot. And then next question, is recovery quicker with Rosa? According to the data, patients recover quicker in the first 6 weeks regarding range of motion, ambulation, and pain control. However, I tell all my patients that the total recovery for a total knee is about 3 months. You walk on it the same day. I send a third of my patients home the same day with a total knee, whether it's conventional or robotic. Is the Rosa knee procedure being performed in Ventura and Ojai? Absolutely. The higher number of cases are being done in Ventura, and that's simply logistics. There's more ORs and there's 2 robots. Is everyone a candidate for a knee replacement with the Rosa robotic technology? Like I said earlier, there's really no reason if you're a candidate for a total knee replacement. So you have to be a candidate for a total knee replacement. That's a whole topic in and of itself. But if you are a candidate for a partial knee replacement or a total knee replacement, you should be a candidate for a robotic one. Does the Rosa robotic device decrease OR time? No, and it's actually the contrary. It actually increases OR time because we have to bring the robot in. It has to be draped sterilely. It takes extra time to place the tracking pins for the tibia, for the femur. There's a little bit increased surgical time, definitely. I'd say it takes many cases, 20 to 40 to 50 cases with the Rosa in order to attempt to decrease it back down to the time that it took to do your traditional knee. We have some more questions coming in. If a knee replacement was unsatisfactory, can it be corrected with the Rosa robot? That's a very interesting question. I think that kind of goes back to the earlier question regarding robotics and revision hip arthroplasty. It could be. These things would be off-label, meaning it's not FDA approved for that. Can it still be done? Yes, but I wouldn't venture into that unless we can find a way to use robotics to help us in those situations. And the way that the current workflow with these robotic knee replacements with the current available systems is such that I don't think it adds much. It would increase the time of the case, and I think it would be better served doing revision hip and knee arthroplasty without a robot at this time until they come up with maybe better algorithms and better workflows for that. And this is the last question. How long does the knee implant last with a Rosa procedure? So knee arthroplasty with the current implants that are being used should last 25 years at about 85%. So 85% of patients that have a total knee, it should get you 25 years. And that's 25 years before the implant starts becoming loose at the bone cement interface. If it's a cementless total knee, then maybe it's 20 years or 25 years prior to the plastic liner having a significant enough wear that it needs to be changed. This also depends on how heavy the patient is, what are the comorbidities, what are they using their total knee for. It's kind of like tires on a car. We don't all drive our cars the same way, and we do different things with our cars. Does the robot in and of itself make the knee last longer? Well, it can. So if you're putting in a total knee in an incorrect alignment, or it's not in an appropriate mechanical alignment for that patient, then it would predispose that knee to not last as long. Thank you for your time. The next speaker that's up is Dr. Pahlavan, and he's going to be going over the Globus Excelsior robot that's used in spine surgery.
Evening, Sohrab Pahlavan, spine surgeon with Ventura Orthopedics. I see patients in Ventura, Camarillo, and Simi Valley. I'm also currently the chief of orthopedic surgery at CMH. It's my pleasure tonight to talk about robotic applications to spine surgery. So my practice is exclusively within neck and spine procedures, and I'm happy and excited to introduce this new technology to our community. So before we go into the robotics portion, I'd like to discuss how the evolution of minimally invasive spinal surgery has come along. And with the new technology and evolution of techniques, it has allowed us to do increasingly less invasive surgery of the spine. And it has its own distinct advantages. One of them are that the patients in general recover much faster. They also have far less complications in terms of infections and blood loss. And these two things in combination turn out to make minimally invasive spine surgery much more cost effective, which is important in modern society with increasing costs of medical care. There are certain drawbacks though. With any new technology or evolving techniques, there is a learning curve. Surgeons in general probably need to have about 30 to 40 cases under their belt before they become very highly competent, and so there is some increasing difficulty with new added technology. There is increased complexity. Every layer of technology that's added requires additional equipment and often requires additional staffing. And so all these things in combination requires that the team has buy-in so that there is a competent team that is committed to using the technology. And that's what we have here at CMH. Further, there's also a spectrum of procedures that can be done minimally invasive, and this has increased over time. Several decades ago, it started off with simple decompressions of nerves, discectomies, laminectomies done through small incisions. That has now evolved into 1 or 2 level lumbar fusions, but now with the advent of robotic spine surgery, in addition to the navigation procedures, it now allows us to do much more complex procedures such as scoliosis, deformities, tumor surgeries, various types of infections, or traumatic injuries. Now, when you have less invasive surgery, it also necessitates using more advanced technology. So the surgeon has to have accurate and real-time information that also has a high level of fidelity and reliability. He or she has to feel confident that the information that's being provided is accurate. Therefore, there have to be fail-safe systems in place, and we also have to realize that technology is a tool. It doesn't replace the surgeon. It enables us, it doesn't replace us. And with that in mind, it does still require a surgeon that is competent and understands the indication and uses it judiciously. Currently we have robotics and we have navigation, and they are in a new system that we're using interconnected. Robotics allows a guided trajectory for placement of implants, such as screws or cages, and it requires registration with imaging that you then merge and allow you to navigate. And navigation is the actual real-time information of how things are in space, and that's what enables us to use the robotic technology. This is the primary system components of the system we are using currently at CMH, and it has a camera for maintenance of navigation fidelity. It has a rigid robotic arm. It has the active end effector, which is the actual piece that we put our tools through, and has a touchscreen monitor that allows real-time information but also adjustment of the plan when needed. This is the basic OR setup. We have the robotic arm at the head of the table, the surgeon, assistants, scrub technicians, and then the surgeon can use the arm and bring it in and out as needed. So this is the first and only robotic navigation platform that has multifunctionality, unique real-time information, and also allows versatility in terms of image acquisition. What we do is we have special reference arrays that allows us to have real-time information. These are placed on the patient rigidly, affixed into the bone most of the time, and these create an environment where we will know at all times that the information we are looking at on the screen is accurate. We also have real-time visualization of our instruments. We can see here on the left the robotic arm with a screwdriver through it, and this allows the surgeon to look at the screen on the right and know what depth, what angle all the instruments are going in. But also in terms of allowing for safety, it has deflection sensing technology to prevent skiving. What that means is that if you're pushing too hard on the robotic arm, it gives you feedback and tells you in terms of force monitoring that you're applying excessive force. So it's an added layer of safety. And also the reference markers, if one of them is moved, it will tell the other reference marker that something has changed and it's time to re-register the images. And this again allows extra safety. So current applications for spinal surgery robots, mainly for placement of screws and rods, and that allows increased accuracy, but also importantly, it allows us to put bigger and longer screws because we know exactly where these screws are going. So there's much more leeway in terms of allowing us to get better fixation. It also allows us to place intradiscal spacers for fusion. And what they do is it allows us to put them in, again, better accuracy, but also allows us to use safer trajectories. We're able to avoid nerves. We're able to preserve anatomy without causing too much damage to the surrounding soft tissues while still achieving the same goals of the surgery. It also allows us real-time three-dimensional spatial information. And that leads to higher efficacy, shorter operating times, which therefore also leads to less blood loss, and then again, faster recoveries. So with that in mind, we'll go to questions. First question getting queued up. So first question is, what type of spinal injuries can be corrected using robotic surgery? So again, really the full gamut of conditions can be treated at this time. I'd say only the very most complex surgeries perhaps are not appropriate for robotic surgery, but ironically enough, it is the most complex surgeries that benefit most from robotic surgery, so arguably you could use it for the full spectrum of disorders. At the moment, cervical procedures are mainly considered off-label by the FDA. These have not yet been cleared fully and will be used off-label. In my personal practice, I do not tend to use robotic surgery for cervical procedures. This is something that has yet to be brought into the mainstream. Next question is, how do I know if I'm a candidate for robotic spine surgery? Well, that is a discussion to be had with your surgeon. Not every spinal surgery requires instrumentation, such as screws and rods, but the ones that do very well may make you a candidate. There are certain extenuating circumstances where, again, it may not be appropriate, but that is definitely a topic to raise with your surgeon. Next question is, will I be given anesthesia during the spine surgery? So in current practice, spine surgery in general is done under general anesthesia. Newer techniques and modalities are being developed that allow so-called awake spinal surgery, but in general, the vast majority of spinal cases are done under general anesthesia, and this is mainly out of safety, airway control, and to allow for patient comfort. And our last question of the evening is there less risk associated with spine surgery if the robot is used? Yes, in many ways, yes. The risks related to implant malplacement, for instance, will be lower. The robotic system allows for higher accuracy of placement of screws. Also, with the improvement in workflow, it allows, decreased issues such as blood loss and, like I said, things like infection and other types of complications. And I think that is our last question. Thank you for joining us tonight. I hope you learned something useful and that this was of help to you. If you want to learn more about our robotic technologies through CMHS, please visit our website at cmhshealth.org. Thank you. Have a good night.